the question is, what is the explanation for the very high prevalence among the HIV positives? As in a lot of African countries, the prevalence of hepatitis C was much lower than in the general population. And even in your, what I saw from your graphs is that it's even higher than in the general population, why you would expect that different, because it's the older population. And the second question is, who's paying for the treatment and diagnostics?
Okay, thank you for the question. For the funding of the program, I think there have been the fund from Global Fund that help to strengthen the hepatitis program. That's how we could do the campaign for testing in the whole country, also for treating.
That's only for the HIV people?
HIV, no. HIV and the other people, everybody. We start by HIV people, then we extend to general population.
Paid by the Global Fund?
Yeah.
Okay, and the other question, what is the reason of the very high prevalence of
Yeah, the high prevalence. We don't know exactly why. It's high prevalence in general population. Okay, this study is, it was a campaign. It was a result of a campaign. We called people for testing, screening. And there was the communication was to all the people to come for testing. But, okay, we had all range of ages, mostly the people more than 40 years old. That's how we got a big number of patients with high prevalence of hepatitis. Anyway, in all cases, we had, even in a practical, clinical practice, we had the people with hepatitis C more than 60 years old. I think the study of prevalence, well-structured study of prevalence that we have to know really the risk factor in young people, especially in young people.
Thank you both for those presentations, and congratulations on the great work that you're doing. There is a relatively high level of political will in both of your countries in addressing viral hepatitis. Can you say what were some of the factors that led to that engagement on the part of the government?
Yeah, because there was a lot of patients dying from hepatitis B and C. You know, after we tackled the problem of the HIV, now the second problem occurred with hepatitis C and B death in referral hospital. And there was also a program of screening people, especially the government servant, for checkup, checkup done once a year. So, and the hepatitis B and C were among the list of tests to be done. That's how we get a big number of patients with the hepatitis B and C. So it was clear that we had to do something for these people, because if once they are tested, and even if they are not sick, but they need, what's the next step? It's been doing viral load, then the treatment. That's how, before 2015, we were able to treat 100 patients in almost 10 years, 8 years, because it was very expensive, but the number were increasing year to year. So it was important to find a solution for those people. So the government take the lead to find the solution to treat. That's why funding for treating, for screening, because if you call people to screen for disease, and you find the disease, so have to go beyond finding the disease.
Thank you.
Treat.
Yes, thank you. Just to come back to the fact that you have many people after the age of 50 were massively infected,
Yes.
means that something must have happened before. So there should be a cohort situation happening, because in Cameroon it is proven that our patients now who are more than 50, means that something may happen between either by the late 50s or the early 60s. Massive immunization program went on, and then probably may explain why most of the patients are aged more than 50. Nevertheless, actually we are witnessing new infection in young people. So all those epidemiological aspects should be tackled and then try to understand why.
Yeah, you are right. You know, there is a lot of program for prevention of disease in the 60s, even 70s, and the reuse of syringe in health facilities, it was common during that period. It's almost till 80s that they start to use one syringe for one people. So I think during this period, a lot of people were infected with the reuse, even the traditional practice, healing practice. So things are changing. That's why you see the younger people less infected than older.
Sorry, thank you very much. I would compliment my colleagues, Dr. Constance, on that we have a high prevalence in people, in aged people. We are conducting a study now that will be published very soon on risk factors for hepatitis C and also for hepatitis B. And that some preliminary results show that we have cultural practice as a traditional surgical, which is being done. And we have many people, about 20% of people aged have been it has been operated traditionally. And that is why we saw that there is also association, statistical associated with prevalence of hepatitis C. That is why more people, aged people who have been operated traditionally were associated with hepatitis C.
Thank you very much. I want to thank the two speakers and congratulate our speaker from Myanmar. I was particularly impressed about the advocacy and the communication that went on, and I would like a word on the strategy that sustains this advocacy. Our speaker from Rwanda, thank you very much for Rwanda is one of our star programs in Africa. And I want to quickly mention, number one, there was a genocide 20 years ago, and over 1 million people died. And it is possible that there's some relationship between that and the higher prevalence in those over 55 years old. It's just a thought. And number two, I note that the call to action for viral hepatitis was based on people dying. And the data shows us that the people are dying a lot from hepatitis B, much more than C. Yet, in the treatment program, I note that hepatitis C patients have viral loads and they are treated based on high viral load, while hepatitis B patients are treated based on the presence of cirrhosis. So, what are the plans to accelerate viral load tests for hepatitis B so that patients at an earlier stage can be picked up and put on care that is readily available. Thank you.
Maybe Dr. Chi, would you like to answer first about the strategy?
Regarding the political will mentioned by Dr. Nimberg, political will is very important because in our country, National Hepatitis Program was formed only in 2015 with the new government and the new health minister. Because the new health minister was previously vice president of Myanmar Liver Foundation, and he knew about the deadly impact of viral hepatitis in Myanmar, because he was one of the persons who was practicing this awareness-raising program. So when he became health minister, he was very determined that National Hepatitis Program is a must in the Ministry of Health. So as soon as he became minister, he formed the National Hepatitis Control Program. And he was actually the first minister actually, who spent a lot of money on this hepatitis C treatment program. Because we started the hepatitis C treatment program last year. So they started in 2,000 patients in 2017 and 2,000 patients in 2018. And also they are treating the hepatitis C patients with a cost-sharing basis. So it will be a phased manner, but it will gradually increase in number for the patients. For hepatitis B also, at the moment they are concentrating on the prevention program like awareness raising and other prevention program, birth dose of hepatitis B vaccination and hepatitis B vaccination in the high-risk groups. But we are hoping that we will be able to start treating the patients. For the molecular tests, we now have a lot of molecular gene express machines for hepatitis C and also Roche machines for hepatitis B at the Ministry of Health.
Thank you for the question. The question number one is linking the genocide and the prevalence of this infection. I think maybe, yes, because the people moved a lot during that period. From they come to outside and they come back. And the other people from outside and coming in. So there is a mix of movement and people. That's why even the prevalence, you were not in regions of the Rwanda. You see where the B is high, it's not where the C is high. So I can imagine what's going on. So it's hard to know exactly what's happening. Maybe the study ongoing will help us to make it clear. We can't understand what's happened. Okay, we know that people moved a lot, but that cannot only explain the differences in prevalence of this infection. Yeah, the second question is about viral load or hepatitis B. Okay, it's a big problem. We know that for C, every patient with the viral load detectable can be treated and cured. But for B, everyone who has antigen doesn't need treatment. So it is very expensive. And so how to find the test which is not expensive, that can be used, because when we talk about this program, it's about money, and money is not enough, even we don't have it. But we have to do things. How can we treat most patients, a big number of patients, without spending a lot of money in testing? That's why we're discussing here this problem. How can we do that? Where can we find the not expensive tests so that we can treat? Okay, there are guidelines for management of hepatitis B, based on, of course, viral load, most the liver enzymes. Once the antigen is positive, they'll monitor liver enzymes. If they are high, patient can be treated without viral load. That is what is in the guidelines, because we cannot rely on the viral load because it's not accessible to patient, even at the level of health center. But I think what things can be worked on is to find the test which we can use to decide to treat without spending a lot of money.
Thank you very much. We're going to have to wrap up here, and thank you so much to all of our speakers. And one thing that I took away from this session was I was very impressed at the prevalence surveys you had all done, which really help you target your testing and plan your strategies. That's something that I took away from this session. But thank you very much, everyone.